Welcome to Raaonline. This is yet another session on infections and diabetes. I'm Dr. Lakshmi, Director and Consultant Physician and Diabetologist, Hariharan Institute of Diabetes, Nanganallur, Chennai. This module we will be dealing with the various kinds of infections that one would come across in patients with diabetes. So to begin with, diabetes and infections are two very commonly seen and commonly associated conditions. Any patient who is a diabetic is quite prone to developing a lot of infections, and there are some infections which have proven association with diabetes and some infections which have a possible association with diabetes. By this I mean, being a diabetic patient confers a risk of getting certain infections like influenza, bacteriuria, malignant otitis externa, rhinocerebral mucormycosis, emphysematous cholecystitis, pyelonephritis, perinephric abscess, urinary tract infection, so on and so forth. So all these are infections which definitely have a proven association with diabetes. And other possible associations are staphylococcal pneumonia, solitary liver abscesses, bacteremia with strep or staph, gram-negative septicemia, other mucocutaneous candidiasis, so on and so forth. So we will be dealing with each one in the following module. So to just give you a bird's eye perspective of the kind of infections that we are going to deal with in this module, we will start with otitis externa, go into mucormycosis, discuss a little bit about TB, candidiasis, emphysematous cholecystitis, UTI, necrotizing fasciitis, Fournier's gangrene, bone and joint infections, and lastly we will touch on diabetic foot infections. So to begin with, malignant otitis externa, first of all, it is considered that this terminology itself is a misnomer because we are not dealing with a cancerous condition. It was so termed probably because of its propensity to cause complications. Necrotizing otitis externa or granulomatous otitis externa may have been a better term. It is basically a necrotitis otitis externa which leads to skull base osteomyelitis that typically affects elderly diabetic patients. The causative organism is usually Pseudomonas aeruginosa. Symptomatology, you typically have a patient that comes to you with a very severe excruciating pain in the ear which worsens at night, foul smelling purulent ear discharge, facial paralysis and involvement of 9, 10 and 11 cranial nerves. The diagnostic physical sign is that there will be a presence of granulation tissue at the bony cartilaginous junction of the external auditory canal. Now if you can remember, this is the section which shows you the external auditory canal and the way in which granulomatous otitis externa can affect. The course of the disease typically starts with a history of a trivial trauma. It can be as simple as just ear picking or just some blunt trauma to the external canal, but that can lead on to cellulitis, leading on to perichondritis, chondritis leading to osteitis, and when that touches the skull base, that is when the problem starts, because this area is extremely, close to all the important structures, because posteriorly you have a tendency for it to get into the mastoid, and medially you have the middle ear cavity, anteriorly you have the TM joint and the TM fossa, inferiorly you have the jugular foramen. So in other words, this is a very, very critical area where the infection can spread in all directions, and for ease of understanding, this is just to depict that an otitis externa can have the propensity to infect any of these areas, be it the jugular foramen, be it the TM joint, be it behind to the mastoid. So everywhere the infection can spread from the external auditory canal, and that is why this is a very, very difficult infection to treat and also important to control because of the anatomic location of this area. So investigations, you will have to obviously send a pus for smear culture and sensitivity, and as I told you, generally the organism that we counter is the Pseudomonas infection, and biopsy is also recommended wherein you see necrotizing vasculitis. A technetium-99 scan is always used for diagnosis, which will remain positive for the entire lifetime of the patient even if the infection is well controlled. A gallium scan can be done for diagnosis and monitoring, which will just show the pickup by the leukocytes. And we all today do a HRCT of the temporal bone to know the extent of the disease with respect to the spread in the skull base is concerned. Treatment, needless to say, one has to control diabetes. Anti-pseudomonal antibiotics for 6 to 8 weeks for osteomyelitis. You can go with ciprofloxacin if you have a culture which is, sensitive to ciprofloxacin. Ceftazidime, piperacillin, tazobactam, because you will have to keep in mind the resistant bugs also. Oral toileting, ear wicks to prevent stenosis. These are all the general, the basic ear hygiene that one has to follow. Surgical drainage of the subperiosteal abscess and removal of necrotic tissue and mastoid exploration and debridement are recommended in extensive cases. Prognosis, the mortality rate in the pre-antibiotic era was more than 50%, but today, thanks to the kind of antibiotics we have a really, really good, cure rate with otitis externa these days. Moving to mucormycosis, I think mucormycosis, we have all become very, very familiar with this topic, especially after the COVID pandemic, because we've been listening about it quite often these days. The causative organism is Rhizopus species or the mucor species. The site of infection can range anywhere. It can be pulmonary, it can be gastrointestinal, it can be rhinocerebral, it can be soft tissue. So these are the various sites where mucor can affect. But ideally, we find a lot of soft tissue and rhinocerebral mucormycosis being very, very common compared to pulmonary and gastrointestinal mucors. So coming to rhinocerebral mucormycosis, this is the commonest form of mucormycosis that we come across. It is definitely a life-threatening infection which, if untreated, is universally fatal. And if recognized early, the survival rate is up to 20%. And the fungi have a predilection to invade the blood vessels, and which is why this is a very, very, dreaded fungal infection, especially when it affects an immunocompromised host. The clinical features are that of nasal stuffiness, epistaxis and facial pain. Later, one can have proptosis, chemosis and ophthalmoplegia. Generalized malaise, fever and confusion is also seen in a few patients. Black eschars can be seen in the nostril or in the palate, and necrotic nasal turbinates are very, very characteristic. I think that is a telltale sign of mucormycosis.